A very good afternoon to all of you. So my topic would be pulmonary diseases with ocular impacts, and I would try to do as much justice as I can with a very short time and a very big topic. So how are pulmonology and ophthalmology linked together? So there can be various mechanisms like immune-mediated mechanisms, hypoxia due to chronic respiratory diseases, then direct spread, uh, both infections and meds. Then various side effects of medications are also link these two departments. Then various autoimmune links are there. So the diseases which are, or the setups which are linking both these departments, they start from simple allergies, asthma, to COPD, tuberculosis, and then to adverse effects of medications, and lastly to cancer. But each of this disease is a huge topic in itself, so I will be limiting my topic to the commonest one, the tuberculosis and the sarcoidosis. So tuberculosis, as we know, is a preventable and usually curable infectious disease. And according to WHO 2022 global report, an estimated 10.6 million people developed TB in 2022, and still India is accounting for 27% of the world's total TB incidence. And about a latent TB, about a quarter of global population is estimated to have infected with TB. So there are few terms I want all of you to get familiar with. What is extrapulmonary tuberculosis? All of you know. Tuberculosis involving lungs, so that we label as extrapulmonary tuberculosis. What is disseminated tuberculosis? Tuberculosis involving more than two non-contiguous organs. So if lungs and pleura are involved, we don't call them non-contiguous, so they'll be a same entity. But if lungs and abdomen or lungs or CNS is involved, so we label them as disseminated tuberculosis. Then biliary, all you know. Then presumptive TB, any patient who is having clinical features suggestive of TB would be, we would label him as presumptive TB. Then MDR, all of you know. MDR means the sample, the patient is resistant to the two important drugs, isoniazid and rifampicin. Then we divide the diagnosis as per microbiological confirmation and clinical diagnosis. So our effort should be always there to microbiologically confirm each case, but in every scenario it is not possible, so we label the patient as clinical diagnosed as per the clinical scenario. So MTB, you all know, it is a strict aerobe, it loves oxygen. So the most common organ it affects is the lungs, and the most common part of the eye, you know, is very well you know, is the choroid. But by the way, how it reaches the eyes, it is mainly through hematogenous dissemination, although there are other ways by how this MTB enters into eye, like direct ocular infection from an exogenous source, such as contact with eyelids or conjunctiva. In this case, we'll label it as primary ocular TB, and a hypersensitivity reaction in eye structures which when exposed to MTB antigens in the blood. But still, the commonest one is the hematogenous spread. Then how will a patient of ocular TB present? It will present with headaches, flashes, floaters, red eyes, diminished visual acuity and photosensitivity, along with or without constitutional symptoms. And as similar to other TB presentations, ocular TB is also a great imitator of various ocular pathologies, and we have to very carefully label the patient as ocular TB. So the various modalities for diagnosis can be clinical history, examination, then radiology, then microbiological confirmation by phenotypic or genotypic testing. So I'll just run through these slides. So various modalities, genotypic tests are CBNAT, TrueNAT, then line probe assay, and these tests, these are not only you can say very fast, but and they do tell the presence of MTB. Along with that, they also tell the pattern of resistance. But still, in this very fast world, the culture remains the gold standard for diagnosing tuberculosis. Though culture is also now has shortened this duration to diagnose the patient, we have liquid culture, that is MGIT. It will give us report within 7 to 10 days. Then genetic sequencing, the whole genome sequence, it can provide a near complete genome of MTB in a sample, but it is only maybe in 1 or 2 centers in India, so it's not very common. Then imaging study, you all know, if you suspect ocular TB, you get a chest radiograph, and but if you have a very high suspicion and chest radiograph is normal, you can order a HRCT, because it is very sensitive, as it is more sensitive as compared to chest X-ray. Then we can also get ultrasound abdomen to look for any abnormality in abdomen to find ascites or any retroperitoneal lymphadenopathy there. Then how we diagnose? So definitive diagnosis is mainly by demonstrating MTB, but obtaining ocular tissue for diagnosis is not only difficult, but also it carries a high morbidity. So clinical suspicion, it remains the key to diagnose ocular TB in an appropriate setting. So these are ancillary tests which help, which add to our diagnosis. These are TST and IGRA. We'll talk about these later also. And you must be knowing these diagnostic categories of ocular TB. Bacteriologically confirmed once you have the microbiological or histopathological confirmation of MTB. Clinically diagnosed when you have an appropriate scenario of probable ocular TB, along with any clinical sign, along with the evidence of chest radiograph of TB infection or any sample positive from any other site. Then possible ocular TB if the patient is having the presence of the following, and like it has one clinical sign suggestive of ocular TB, but CT and chest CT is not consistent, no evidence of extraocular TB, then patient should have a history of documented exposure to TB, any immunological evidence to TB infection, or some molecular evidence of MTB infection. Treatment, everyone of you knows how to treat TB. So it has two phases, intensive and continuation phase, and the duration is usually 6 to 9 months. But where is the confusion? To give or not to give steroids. So as per the index TB guidelines, the Indian guidelines for extrapulmonary TB, they say the paramacular and optic nerve head TB, they require treatment with ATT along with steroids. And then you would wonder while you prescribe the patient ATT, after a few weeks he comes with a worsening of symptoms. So there is a term called paradoxical worsening of the symptoms. So what happens is the immune system, it regains increased exposure to bacterial antigen after the treatment has started. It released pro-inflammatory, more of the pro-inflammatory cytokines, leading to more of the symptoms and reappearance of the symptoms. So what to do now? So first of all, you have to exclude every other diagnosis of the disease, of any other disease, alternate diagnosis. Then you have to rule out MDR-TB. Then once you label the paradoxical worsening, then you can simply assure the patient and continue with ATT, or you can start with corticosteroid treatment, which can circumvent this phenomena. Then one slide about latent TB. What is latent TB? Latent TB infection is defined as evidence of TB infection without evidence of active TB disease clinical manifestations. So how to diagnose? We have only two tests available in this scenario. We have TST, that is tuberculin skin test, most commonly known as MANTO testing, and IGRA, that is interferon gamma release assay. So when to label a patient having MANTO positivity? So PPT is injected intradermally and the reading is taken 48 to 72 hours later, and it is a type 4 hypersensitivity based reaction. So if the induration is just more than 5 mm but the patient is HIV positive or an organ transplant candidate, then we label a MANTO positive. If the patient is having more than 10 mm of induration, patient is having any malnutrition, patient is severely malnourished, patient has diabetes, uncontrolled, patient is on chronic corticosteroid use, then we can label the patient as having positive MANTO. In every other scenario, in an immunocompetent patient, we label MANTO positivity if the induration is more than 15 mm. And also it is limited by various things. Dr. like
Komal,
yes.
If you'd just like to wind it up.
Okay, right, ma'am, right. Okay, so how can we compare TST and IGRA? We know both of these are sensitive, but the IGRA, it has high sensitivity, high specificity also in BCG vaccinated and in TB endemic countries like us, but it requires a huge lab and infrastructure setup, and the cost of test is high. So just one slide about TPT, because many a times we get a patient with MAN2 positivity, normal X-ray, and some ocular features. Now what to do? So if patient is having any highly MAN2 positivity, then we should definitely look for any active disease, active TB disease. Otherwise, the target population for TPT is mainly the household contact of the patients who are having sputum positive, the patient of sputum positive pulmonary TB. Second thing are the patients, the children or adults on immunosuppressive, long-term immunosuppressive therapy. Second, one occupation, silicosis is being given TPT. Then if the patient is put on anti-TNF treatment, patient is to put on long-term dialysis or a transplant candidate. Only these are the settings where we have to give TPT as per the latest TPT guidelines. So you all know what are the drugs which can cause ocular toxicity. We know ethambutol, linezolid are the main drugs in concern. Then very quickly, I'll run through the sarcoidosis slides for sarcoidosis. It is inflammatory. We know inflammatory multisystem disorder of unknown etiology. It is characterized by non-caseating granulomas. So why does it happen? There is an exaggerated cell-mediated immune response to unidentified antigens, and these aggregations of multinuclear giant cells, lymphocytes, they all form a non-caseating granuloma, which will then lead to symptoms in a patient.
Dr. Komal, may we just request you for the concluding slide, please?
Okay, ma'am. Okay, right. So, okay, so treatment you all know. So this is the just one moment that Lofgren syndrome doesn't need any histopathological sample. It is acute disease. Then Hereford syndrome you all know. Indications. Do I treat all sarcoidosis treatment, all sarcoidosis patient? No, I will just treat only the patient who have threatened organ failure. Treatment, we all know, the basic principles is to prevent the end organ damage and to prevent the recurrences. And fortunately, it is a very steroid responsive disease. It has a long term steroid course, the timeline is long, maybe more than 1 year. The disease, and if steroids are not, the patient is not responding or having side effects or having contraindication to steroid, then we can go for the second line disease. So TB and sarcoidosis, they are like Sita and Gita, so they will look same. They are both chronic diseases, both are granulomatous diseases, both can have same clinical presentation, but they behave differently. So, and they have different treatment. So we have to identify them very correctly. And last but not the least, it is always a team effort. And if I'm not, you can say, taking help of my ophthalmologist, I will diagnose an elephant as a wall simply. So I'm thankful that they give me a call, and I also give them a call when we are in the middle of the confusion of a diagnosis of a patient. And thank you so much for having us with me. Thank you, ma'am. Thank you so much.